now. This week we have yet another terrific fellows debate. This week we've got Drs. Emily Ong and Dr. Yanting Wang debating the use of primary prevention ICDs in non-ischemic cardiomyopathy. I will now turn the mic over to Dr. Enriquez, who will introduce the first speaker.
Good morning, everyone. So Emily went to undergraduate at Cornell University, where she graduated cum laude. She then went to the great city of Philadelphia for medical school at Drexel University before going to New York City at Albert Einstein Montefiore for her residency. She came here last year actually to pursue cardiology, and she's one of our enlightened fellows as she has decided to pursue electrophysiology. She will be arguing the pro side for ICD therapy in non-ischemic cardiomyopathy.
Thank you, Dr. Enriquez. So today we're going to be discussing the use of primary prevention ICDs in non-ischemic cardiomyopathy. And I will be discussing the evidence for its use, as well as criticism of some of the data that goes against it, and as well as talking through the meta-analysis data that supports its use. So, as you know, patients who have systolic heart failure are at risk for life-threatening ventricular arrhythmias that can lead to sudden cardiac death. Primary prevention ICDs to prevent sudden cardiac death. Those patients who have significant reductions in appear to be risk. And there's a large body of evidence to
Hold on one second, Emily. Can everybody please make sure that if you're not Emily, you're muted, because there's a substantial amount of noise. Thank you.
And so those patients who have a substantial reduction in EF appear to be at the highest risk. We have a large body of evidence support the use of primary prevention ICDs in patients with ischemic cardiomyopathy, particularly the Meta trials show good evidence for this. But the question is, what do we do about patients with non-ischemic cardiomyopathy? What is the evidence in these patients? So our current guidelines suggest that in patients who have non-ischemic cardiomyopathy, who have class 2 or 3 symptoms and an EF of 35% or less, despite medical therapy, that we should put an ICD in patients who are expected to have more than 1 year survival. A less strong recommendation for patients who have class 1 symptoms, and then recommending against for patients who have class 4 heart failure who are not otherwise a candidate for a CRT device or advanced therapies. And so what is the evidence that is the basis for this recommendation, that we should place ICDs in patients for primary prevention and non-ischemics? And so I want to start with the DEFINITE trial, which was published in 2004. And so the purpose of this trial was to see if there was a value in giving people primary prevention ICDs in patients who have non-ischemic cardiomyopathy. This was a prospective randomized controlled trial, and the patients that were studied were those who had symptomatic heart failure, were non-ischemic with an EF of less than 36%, and had ambient arrhythmias, which they defined as NSVT or PVCs. And the two groups here were patients, one arm got just standard oral medical therapy, and the other group got the same plus an ICD. And the endpoint that we studied was death from any cause, and secondary endpoints were death from arrhythmia. And so the results of this trial show that there is a significant decrease in death from arrhythmias in the ICD group as compared to patients who received only standard therapy. And the hazard ratio in terms of the risk of sudden cardiac death was 0.2, and this was a significant finding. And then overall, in terms of all-cause mortality, so fewer patients died in the ICD group, and there is a trend toward reduction in death from any cause, although this does not quite meet significance. But I think one of the important things to note about this study is that it was designed to have 85% power to detect detect a 50% reduction in mortality in the ICD group, which they did not actually achieve. And so it is a little underpowered in terms of detecting a benefit in death from any cause. And then another thing to mention is that there was a high proportion of non-cardiac death in the study as well. And so that would essentially dilute the benefit of ICD since patients are dying from competing non-cardiac causes. And so 38% of patients in this study did die from other things such as cancer, pneumonia, drug overdose, suicide. And so those would be things that would lower the benefit of ICD in this particular study. But I think what is important to note is that there clearly is evidence suggesting that ICDs do what they are meant to do, which is decrease sudden cardiac death from arrhythmias. Sort of going against what people have often said about non-ischemic patients, you know, they don't have much ventricular arrhythmias, you know, they don't really get shocked from their ICDs. 17% of patients in this study who received an ICD did actually get shocked appropriately. And as compared to sort of a low risk of complications. So in this study, only 1.3% of patients had a complication during implantation of their device. There were no procedure-related deaths. And long-term, there was only a 4.4% of device-related complications. The next trial that I want to talk about is SCD-HEFT, and this was published in 2005 in the New England Journal. And the purpose of this study was to see if treatment with amiodarone versus an ICD as compared to standard oral medical therapy would improve mortality in heart failure patients. Again, this was a randomized controlled trial. This study had both ischemic and non-ischemic patients, but they were about half and half. 48% of the patients studied were non-ischemic. And the patients had class 2 or 3 heart failure with an AF of 35% or less. And so there were 3 arms in this study, medical therapy plus placebo, medical therapy plus amiodarone, and then medical therapy plus an ICD. And the endpoint that was studied was death from any cause. And so in this study, you know, amiodarone was found to have no benefit in reducing risk of death. But for ICDs, there was a decreased risk of death. The hazard ratio was 0.77, and this was a significant finding. And so, you know, then you might ask, well, there's ischemic patients in this study. So if we break it down into the 2 subgroups, the decrease in the risk of death did not vary by the cause of CHF. And so both ischemic and non-ischemic patients had a reduction in death. Now, in this case, both subgroups are underpowered, but both ischemic and non-ischemic had a similar reduction in mortality. And so in this particular study, 31% of patients received a shock, and 21% of those patients were appropriately shocked from a ventricular arrhythmia. And so again, there is a benefit to the ICD in doing what it does best, which is prevent sudden cardiac death. And again, there is a low risk of complication with only about 5% rate of acute complications and overall 9% chronic. And so next I want to discuss Companion. This was a trial also in 2004. And this trial looked particularly at CRT therapy, either CRTP or CRTD, whether that reduced the risk of death and hospitalization in heart failure patients. And so this trial also had ischemic and non-ischemic patients, with about 45% of the patients being non-ischemic. This particular trial had patients that were in class 3 or 4, New York Heart Association heart failure. And in this study, they looked at patients who had prolonged QRS of at least 120, and who had also had been hospitalized for heart failure within the last year. And so there were 3 groups, one receiving medical therapy, one with medical therapy plus a CRTP, and one with medical therapy plus a CRTD. And the study looked at death from any cause or hospitalization from any cause, with some secondary outcomes being just death alone, death from or hospitalization from cardiac causes, and then specifically death or hospitalization from heart failure. So ultimately what this study found was that for all of the endpoints, there is a reduction with device therapy, and specifically CRTD showed a significant reduction in all of the outcomes. And so the primary endpoint, which is hospitalization or death, both CRTP and CRTD show a significant reduction. And then specifically in terms of death from any cause, CRTD showed a 36% reduction in death, and this was a significant finding. And similarly for hospitalization or death from cardiac causes, or hospitalization and death from heart failure, both CRTP and CRTD reduced the risk of both of these outcomes, and those findings are significant. So just looking at the Kaplan-Meier curves here, as I mentioned, in all of the outcomes, a CRTD reduces the risk of hospitalization, all-cause death, hospitalization and death from cardiac causes, and from heart failure as well. And so again, you know, the question might be, well, what about specifically in the non-ischemic group? And so if you look at their analysis from the subgroups, in non-ischemic patients, CRTD compared with pharmacologic therapy does significantly reduce the risk of death, and in the patients who have non-ischemic cardiomyopathy. And the hazard ratio here was actually 0.5. And again, as I mentioned, this is a significant finding. And so I know that one of the studies that people mention all the time when they talk about potentially saying, you know, ICDs in non-ischemic patients are not of benefit, people mention the DANISH study. And so I want to talk about the DANISH study, as well as go over reasons why I think this is not necessarily a good reason to not implant a primary prevention ICD in patients. So the DANISH study was published in 2016. And basically, the idea was to study whether or not primary prevention ICDs would benefit patients with non-ischemic cardiomyopathy. And so again, patients with symptomatic heart failure who are non-ischemic with an EF of 35% or less were the patient population. And in this case, what is, I think, important to note is that their interventions, the two groups that were studied were patients who got what they called usual clinical care, but this was defined as oral medical therapy, as well as with a CRT if patients qualified. And then the intervention arm was basically the same thing, medical therapy with a CRT, but plus a defibrillator. And so this looked at the endpoints of death from any cause, as well as the secondary endpoint of sudden cardiac death and cardiovascular death. And so the DANISH study basically showed that for all-cause mortality, so death from any cause, there does not seem to be a difference in the patients who received an ICD. But when you look at it, you know, when you look through the data of the study, there is a significant difference in sudden cardiac death. And so the patients who received an ICD did have a significant reduction in the risk of sudden cardiac death. And again, the hazard ratio here was 0.5. And as I mentioned earlier, I think one of the really important things to note is that the non-ICD arm still actually received devices. And so 58% of patients in both arms, so the non-defibrillator as well as the defibrillator arm, 58% of patients received a CRT. And so essentially what we're looking at is where a majority of patients in both arms of the study actually did receive a device. And, you know, as we sort of saw with the companion study in the past, a CRTP alone seems to also have mortality benefit. And so, you know, possibly one of the reasons why we lose some of the mortality benefit from the ICD itself in this study is because a majority of patients in the control group had a CRT. And you know, one of the arguments for not placing a device in patient is the risk of complications from having the device, either acutely during placement or long term. If most patients are getting a CRT, this risk is then going to be present regardless. And so that sort of negates the point where, placing a device, has a risk of complication. Well, if patients are going to get a CRTP, then they're similarly going to have device-related complications. And I think so in this situation, it's hard to really extrapolate the data from this study to patients who don't necessarily qualify for a CRT, because actually a majority of the patients in this study did in fact qualify for one and get one. Another thing to note in the Danish study is that a large proportion of the patients had suffered from non-cardiac death. And so 31% of deaths in the study were non-cardiac. And again, that would basically reduce the benefit that we see from an ICD, since an ICD obviously is designed to prevent sudden cardiac death. It's not going to have any effect on anything that's non-cardiac. Another thing about the Danish study is that in subgroup analysis, when you look at patients who are younger, so those who are younger than 68 years of age, there is a significantly lower rate of death from any cause. And this is a significant finding. And so it goes with sort of what we understand, which is patients who have a higher risk of death from other non-cardiac causes, particularly with advancing age, that seems to diminish the effect of ICD. But in patients who may not necessarily die from something else, that there does seem to be a benefit from having an ICD implanted. And then other things to note in the Danish study is that, all the patients that they studied were Danish. And so, it doesn't have the same kind of racial and ethnic heterogeneity as we see here in the United States. Their exclusion criteria, they basically excluded patients who'd had an episode of AFib with RVR in the past 3 months. And so, it is not something that we would want to generalize to every single patient. So I mentioned earlier that, a lot of the data that we have in these randomized controlled trials is, many of the studies were underpowered. And then when we do subgroup analysis for these studies to look at the non-ischemic patients, there are fewer numbers of patients, and so much of this is underpowered. So in recent years, there have been a number of meta-analyses basically pooling all of this data so that we can get better power to really look at what happens with these non-ischemic patients who get an ICD. And so one of the meta-analyses from Gawal et al. That was published in Circulation, this basically looked at the 6 major randomized controlled trials that we have looking at patients who have non-ischemic cardiomyopathy who get an ICD. So that includes the 4 studies that I just talked about, as well as 2 other very small studies where there are only about 100 patients each. Basically, once we pool all of the data that we have from the available RCTs, we do see that there is a statistically significant risk reduction in all-cause mortality. And so there's a 23% risk reduction in favor of ICD therapy. An important thing to note is that even if we, remove the patients who received a CRT, so, taking that out of the picture, if we just look at ICD with medical therapy versus medical therapy alone, there is still a significant reduction in an all-cause mortality of 24%. When we look at patients just who have a CRT, so comparing patients with a CRTP plus medical therapy versus patients with a CRTD plus medical therapy, there's a trend toward decrease in benefit, but does not quite meet statistical significance. But again, I think the thing to note here is that both sides do have a device, and of course there are smaller numbers of patients. And another thing is that regardless of which study you remove from the meta-analysis, so when you do a sensitivity analysis, omitting each trial and return still yields the same outcome, that there is a significant reduction in mortality with ICD therapy. And so just looking here, basically, when you combine all the trials or looking at the trials that only, in excluding CRT, there is a significant benefit in reducing mortality with an ICD. There was also a Cochrane review that looked at the same things, particularly in this study, they looked at the data for sudden cardiac death, and as we would expect, about the hazard ratio becomes 0.45 with an ICD in terms of reducing sudden cardiac death. So one of the things that is frequently brought up is that patients can receive an inappropriate shock from an ICD, and that this has a significant detriment to their life. Certainly, no one wants their patient to have an inappropriate shock, but from what data that we do have, there doesn't seem to be a decrease in quality of life in patients who have an ICD. And really only one study looked into this data, but within the DEFINITE trial, when they look at quality of life before shock and after shock, there is no significant reduction in the quality of life in these patients. Another thing to note is that we have methods to reduce the risk of inappropriate therapy. And as we can see from one of the trials made at RIT, basically, this study looked at whether different programming strategies could help reduce inappropriate therapy for patients with ICDs. And we do find that if we use high rate programming or have a delay in therapy for lower rates, as compared with conventional programming, that there is a reduction in inappropriate therapy without losing the mortality benefit of an ICD. And so, I think this is something that can be dealt with appropriate programming to reduce the risk of inappropriate shock in patients. And so if you see here, basically with adjustments in the programming, actually not quite 3% of patients receive an inappropriate shock. And so finally, this was actually recently published about 2 weeks ago. And so SCD-HEFT, basically they looked at the long-term outcomes for this study in patient, and basically it's about 11 years of follow-up. And so since the original study was published, they basically looked at the mortality outcomes for the patients who were still alive at the end of the original trial. And so there is still a benefit in the ICD group with a reduction of mortality. But then the question is so what about the non-ischemic subgroup? And so some people might mention, hey, look, it looks like the mortality curves start to converge at the 12-year mark. And so, maybe there's no benefit to giving these patients an ICD. Well, if you look at the patients, a majority of patients actually after the original study ended up getting an ICD. And so these patients, basically a majority of them get a defibrillator. And so I think that really makes the mortality analysis pretty much worthless at that point, because when we're looking at the patients who actually get an ICD, if you talk about the as treated analysis, there is still a benefit of ICD. And so I think looking at this really, I think it just reemphasizes the fact that if you then give everyone an ICD, they still benefit from it. And so overall, I just want to conclude with, patients who have non-ischemic cardiomyopathy, although they seem to have a lower rate of ventricular arrhythmias as compared to patients who are ischemic, arrhythmic death still occurs in these patients. And so what data that we have available does show that there is a reduced mortality in non-ischemic patients who receive an ICD. We have only a few studies that are largely underpowered, but when we put them all together and combine all these studies in meta-analyses, we see that there is a statistically significant 23% risk reduction in all-cause mortality in favor of ICDs in patients who are non-ischemic. The DANISH trial, as I mentioned, there is a benefit and reduction in sudden cardiac death in this study, despite its flaws. And then overall, other things that people are concerned about, things like device-related complications. There is a low rate of complications, and in terms of inappropriate shocks, we have programming strategies to reduce the rate of this. And so overall, with non-ischemic patients, they clearly still have ventricular arrhythmias and are at risk for sudden cardiac death. And in studies like DEFINITE, 17% of patients get an appropriate shock. And so I think that to say that these patients should not receive an ICD, I think that would be inappropriate. And like I said, what data we have suggests that there is a mortality benefit. And so I think we should continue to implant ICDs as the guidelines suggest. And so these are my references for anyone interested. And I want to give a big thank you for Dr. Enriquez and Dr. Friedman, who are our mentors for this debate, and putting all the time and effort, especially in a kind of crazy week where everyone lost power and internet. And so I really want to thank them for their help. And then with that, I'm going to pass over to Ting.
Thank you very much. I had the pleasure of helping to primarily mentor Dr. Yanting Wang for her rebuttal, arguing that we should not be broadly using primary prevention ICDs in patients with non-ischemic cardiomyopathy. Dr. Wang earned a bachelor's degree from Cornell University, actually my alma mater, and subsequently attended medical school at the University of Pittsburgh. She subsequently did an internship and residency at the University of Pittsburgh Medical Center, where she actually was involved in some cardiac resynchronization therapy research with Dr. Samir Saba there. She subsequently, as everyone knows, came to New Haven for her cardiology fellowship. And when she's done with training, she plans on focusing on non-invasive cardiology with a specific focus on women's cardiovascular disease, including cardiovascular disease in pregnancy, autoimmune disorders, and also performing research in disparities in healthcare utilization research. So with that, I will pass the microphone over to Dr. Wang.
Thank you, Dr. Freeman, for providing this introduction. And I would like to counter my opponent, Dr. Ong, with her standpoint of universal use of ICDs in patients with non-ischemic cardiomyopathy. The use of ICDs has been shown to be a major advancement in the care of patients with ischemic cardiomyopathy and EF of less than 35%. However, the evidence for non-ischemic cardiomyopathy is less robust. Non-ischemic cardiomyopathy has traditionally been defined in clinical trials as any cardiomyopathy where there is no degree of coronary artery disease that could explain the degree of systolic dysfunction. However, non-ischemic cardiomyopathy is in fact made up of a heterogeneous group of disease such as sarcoid, Chagas disease, familial or genetic cardiomyopathies, hemochromatosis, peripartum cardiomyopathy, and many more. There has not yet been a single definitive trial to show statistically significant benefits of ICDs in non-ischemic cardiomyopathy patients alone. The current guidelines, both American and European, for primary prevention ICD placements in non-ischemic cardiomyopathy is based on subgroup analyses or meta-analyses. Often these trials have an underutilization of optimal medical therapy or before the advent of cardiac resynchronization therapy, which has drastically changed the prognosis of patients with heart failure. Furthermore, newer pharmacologic agents along with these devices lead to even lower risk of sudden cardiac death, such that the incremental benefit of ICDs are further diminished. Therefore, non-selective ICD usage and implantation as dictated by the current guidelines needs to be revisited, using better prognostic tools and improved imaging modalities such as cardiac MRI. As Dr. Ong has extensively reviewed the prior studies involving ICD usage, I will only briefly go over them, focusing on the design and applicability to our non-ischemic patients. As you can see, there have been multiple trials involving ischemic cardiomyopathy patients, but only 3 trials targeted specifically for non-ischemic patients. One of the first trials was in 2003, was the AMIOVERT trial. This trial enrolled patients with non-ischemic cardiomyopathy at NYHA class 1 to 3 and compared patients with optimal medical therapy and amiodarone to optimal medical therapy with an ICD. In this trial of 103 patients, there was no significant difference between ICD and the control group for all-cause mortality. The ICD group appeared to have better arrhythmia-free survival. However, this was also not significant. Additionally, beta blocker usage was significantly underutilized in the study. Only 50% of the patients were on beta blockers and only 80% were in ACE or ARB. A year later, the DEFINITE trial also looked at cardiomyopathy patients with non-ischemic etiology and ICD placement. Like the prior trials, the ICDs were solely a shock box and were the basic functions, no ATP function and only a shock function. There was no CRT available in this study as well. In regards to the medical therapy, utilization was slightly better than the prior AmioVert study. However, it was still suboptimal with beta blocker usage only at 80% and ACE and ARB at 90%. This trial also did not significantly show any difference in all-cause mortality between the groups. Although there was a statistical significance in an arrhythmia-free trial in the ICD compared to the standard therapy, only 1/3 of the deaths from the standard therapy group were due to arrhythmia. As Dr. Ong had mentioned, there was a high rate of non-cardiac death and non-arrhythmic death. Additionally, there was a low rate in also the control group. This suggests that the increased use of beta blockers and ACE inhibitors in this trial rather than ICD implantation perhaps lowered the risk of sudden cardiac death. Again, biventricular devices and CRT devices were not available at this time. However, 1 in 5 of these patients would have qualified for CRT device placement had it been done in the contemporary era. In 2005, the landmark SCD-HEFT trial came out, and this trial that majorly influenced our current guidelines for class 1 indication of ICD and non-ischemic patients. This trial included, however, both ischemic and non-ischemic cardiomyopathy patients with class 2 and 3 heart failure. As you note, however, there was a significant underutilization of beta blockers at only 69% of patients, and 80% of patients were on ACE or an ARB. In this combined non-ischemic and ischemic group, there was a significant mortality benefit in the ICD therapy with a hazard ratio of 0.77. However, likely this was driven mainly by the ischemic cardiomyopathy group rather than the non-ischemic group. When we look at the subgroup analysis and non-ischemic patients alone, the ICD group did not reach significance, despite what was thought to be a trend toward mortality. However, again, this initial group of patients did not include CRT devices, as these devices were still investigational at this time. The results of the original SCD-HEFT trial were re-reviewed recently after the 10-year follow-up period ended. The ICD benefit persisted in the ischemic group. However, as we look in the non-ischemic group, after the extended follow-up period, mortality converged, and it becomes clear there is no benefit in the ICD group within the non-ischemic patients. One hypothesis to explain why this convergence occurred was the later use of CRT device. In the years following initial randomization, patients in the ICD group received CRT upgrade, and those in the control and amiodarone group also received de novo CRT ICD placements. Again, this emphasizes the lack of incremental benefit of ICD in the age of newer medical therapies, as well as device therapies such as CRT. However, this paper did not directly compare CRT pacemaker compared to CRT ICD, and the mortality benefit may be from the usage of CRT rather than the usage of ICD functions. In the companion trial, it was also published in the same year as the SCD-HEFT, and here it looked at CRT devices in heart failure. This study included both ischemic and non-ischemic patients with heart failure. As noted, however, this patient group was a lot more sicker than the prior trials, including only class 3 and class 4 patients. In this mixed population of both non-ischemic and ischemic patients, both CRT pacemaker and CRT ICD had improved outcomes for all-cause mortality, death, and hospitalization compared to the optimal medical therapy. Both groups had risk reduction of approximately 19%, suggesting that the treatment effect was in fact due to CRT and not from the influence of implantable defibrillator. In the subgroup analysis among patients with non-ischemic cardiomyopathy, CRT pacemaker and CRT ICD were both associated with a lower risk of cardiac death from any cause compared to optimal medical therapy, each with a hazard ratio of less than 1.0. The study itself, however, was not designed, nor was it powered to detect differences between CRT pacemaker and CRT defibrillator. Therefore, the convention of choosing a CRT defibrillator over a CRT pacemaker is based on a premise that ICD will add additional benefit to the CRT device rather than direct evidence itself. The DANISH trial came out in 2016 and is a recent trial that challenged our current stance on ICD placements in non-ischemic cardiomyopathy. It included the most recent optimal medical therapy along with device therapies. The DANISH trial is the best study thus far with the most medication usage at 95 to 98% for beta blockers, ACE inhibitors, ARBs, mineralocorticoid receptor antagonists. And additionally, as Dr. Ong had mentioned, the fact that there was a high use of CRT device in both arms, approximately 58%, is a rather positive aspect of this study, something prior studies have lacked and is now considered the standard of care for those who qualify, allowing us to better understand how much ICD therapy adds in addition to CRT therapy. In the DANISH trial, there was no statistical significance between the standard therapy group and the ICD group for all-cause mortality and for cardiovascular mortality. Additionally, there was no benefit in cardiac arrest, VT required intervention. Sudden cardiac death occurred in 8.2% of the control group and 4.3% in the ICD group, with statistical significance and a hazard ratio of 0.5. However, as in prior studies, the actual SCD event rate for both groups is considerably low, lower than expected, and the proportional rate of SCD compared to overall mortality is even lower. This gets to the basic rule of diminishing returns, that the lower the event rate, the harder it becomes for an additional therapy to benefit. In the subgroup analysis, age was the only factor that was significant. In patients younger than 68, the rate of death from any cause was significantly lower in the ICD group. The effect of ICD implantation was independent of the CRT status itself. And as noted by Dr. Ong, there are multiple meta-analyses which have attempted to pull data from the trials listed previously for a better understanding of ICD benefit in non-ischemic cardiomyopathy. However, it is important to remember that these trials have significantly underutilized mortality-altering medications, such as beta blockers, ACE and ARBs, inhibitors, as well as device therapies, including CRT devices. Additionally, no randomized controlled trial has looked at the effect of CRT-P versus CRT-D. Therefore, the actual benefits of ICD may be overestimated. Again, drug therapies and CRT devices both reduce heart failure death, all-cause mortality, and sudden death, whereas ICDs itself theoretically only reduces sudden cardiac death. While maximizing optimal medical therapy, utilization of device therapies, the addition of ICD may be of little value itself. In the era of improving medical therapy, the risk of spontaneous cardiac death and heart failure is steadily declining. Authors of this study analyzed primary patient data from all the major trials that occurred in 1995 to 2014. Any patients with pre-existing ICD at the start of the trial enrollment was excluded from this paper. As shown in the figure, there has been a sequential reduction of SCD by 44% over the past 19 years, and this correlated with the addition of newer medications. Looking at the ICD usage across the nation, we see that despite a high rate of ICD implantation at over 75,000 per year, only about 5 to 10% of patients actually receive shocks. This rate is now even subsequently lower with newer ICD programming. Additionally, most patients who are older and die from non-cardiac deaths or non-SCD prior to receiving any shocks. The evidence for ICD benefit in non-ischemic cardiomyopathy is rather weak as well. We're left with asking ourselves the question, who should really get an ICD and who will benefit the most? Risk prediction models can stratify patients to those who would benefit the most out of ICDs. The Seattle heart failure models validated to predict all-cause mortality in those with a reduced ejection fraction. And the Seattle proportional risk model aims to predict the proportion of sudden death versus non-sudden death. The Seattle heart failure model can be easily found online. However, it is also important to realize the etiology of heart failure is important and is weighed heavily in this model. The ischemic versus non-ischemic cardiomyopathy has a hazard ratio of 1.4 in the univariate analysis and 1.3 in the multivariate analysis. Again, the Seattle proportional risk model can also be easily found online at the website listed, and these are the variables involved. Authors of the Seattle Research Group sought to utilize these models to better understand the survival benefit of ICDs in non-ischemic patients. Patients who underwent primary prevention ICD placements per the NCDR database were compared to patients who were without ICDs. In the study, the Seattle heart failure model was strongly associated with all-cause mortality. Lower all-cause mortality as predicted by the Seattle heart failure model, and those with high risk of sudden death as predicted by the Seattle proportional risk model. The study also looked at the interaction of age and mortality benefit in non-ischemic cardiomyopathy patients. In agreement with the DANISH trial, the patients who are older than 68 do not benefit from ICDs. However, as you note, the confidence interval in the study is rather wide and can suggest that perhaps some older patients can benefit from ICDs as well. And it is our job to determine and define who these patients are. In the era of cardiac MRI, we can now use imaging to further stratify our patients. In this meta-analysis, looking at late gadolinium enhancement in patients with non-ischemic cardiomyopathy, those with no LGE indicative of SCAR has significantly less sudden cardiac death and less all-cause mortality. In another study, the authors Clement al. tested if myocardial scarring by cardiac MRI could assist in ICD placement and risk stratification. This was a single center study where 135 patients underwent cardiac MRI prior to ICD placement. Whereas the rate of adverse events steadily increased as the LVEF worsened as expected, there was a sharp step up in ICD discharges when more than 5% of SCAR was detected on cardiac MRI. And among those with an LVEF less than 30% and a SCAR of more than 5%, there was a significant increase in death or ICD discharges. Recent studies such as Danish trial have cast doubt on whether an ICD adds to the benefit of a CRT therapy. There may still be a role of the CRT defibrillator if patients are at continued risk for spontaneous cardiac death. Cardiac MRI can also be utilized to choose between CRT-P and CRT-D. In this study by Levia et al., they looked at the total of 252 patients with non-ischemic cardiomyopathy and risk stratified them by cardiac MRI. They looked at mid-wall fibrosis, which is a specific form of myocardial scar found in approximately 30% of patients with non-ischemic cardiomyopathy, and this may portend worse outcomes for patients. In a study that included 68 patients with myocardial scar and 184 without, CRT-D was only beneficial in those with myocardial scar, and CRT-P and CRT-D had no difference in those without myocardial scar. This concludes the talk, and I will leave you all with some important take-home points. Non-ischemic cardiomyopathy is a heterogeneous group of diseases ranging from familial cardiomyopathies to infiltrated diseases such as sarcoid or hemochromatosis, and many more. The current guideline is a one-size-fits-all model and is based on LVF and do not provide the necessary granularity to determine which patient actually need an ICD and which do not. The CRT devices have significantly reduced the risk of spontaneous cardiac death and should be accounted for when considering the addition of ICD. We need to work hard at getting all of our patients on maximal goal-directed medical therapy. The benefits of ICD is significantly blunted in the advent of an increased utilization of mortality-altering medications such as an ACE and ARB and the device therapy of CRT. Additionally, we have even newer medications that significantly alter mortality, such as an ARNI or SGL2 inhibitor. Risk models and cardiac MRI imaging are useful tools to help assess the risk of spontaneous death and determining the benefits of ICD in our patients. I would like all of us to start rethinking about usage of ICDs in non-ischemic cardiomyopathy. ICDs may not be beneficial in people who are older, above age of 65, sicker, as predicted by the Seattle heart failure model, who are more likely to die from non-cardiac deaths or non-sudden cardiac death. Lower risk of sudden cardiac death as predicted by the Seattle proportional risk model, and candidates who are on cardiac resynchronization therapy. Additionally, patients who have no late gadolinium enhancement on cardiac MRI, and those who are already on maximum medical therapy. Thank you. These are my references.
That was a great job. Emily and Ting, I'd like to thank both of you for doing such a thorough work on this and presenting each side of the argument well. I'm going to try and reemphasize some points that have been made, as well as make a few other ones. I actually can't share my screen. I'm not sure, Elizabeth, if there's any way to fix that. There we go. So the first thing I just want to touch base on real quick is, we've known for a long time that CRTP has a mortality benefit, or suggested their mortality benefit in addition to optimal medical therapy. Companion already talked about, but there's also CARE-HF back in 2004 that looked at CRTP versus medical therapy, and there was a statistically different, significant decrease in mortality with CRTP alone. And so I think there's still a debate about the incremental benefit of a defibrillator. I will say that that's kind of almost a mini debate within this, which I won't spend too much time talking about, but I will mention that in both CARE-HF and Companion, CRTP did not reduce the risk of sudden cardiac death. And there are some meta-analyses that do show statistically significant benefit in terms of all-cause mortality for CRTD versus CRTP. The other point that Ting made, which is an important one, is medical therapy is really underutilized, and if we can get people on good medical therapy and optimal doses, I do think that people do better from a sudden death standpoint. The problem is that we're terrible at it. If on this left graph over here, on this figure, this is from a study looking at NCDR coupling with Medicare prescription data in the 90 days prior to primary prevention ICD implantation. And what you'll see is only 61.1% of patients actually filled a prescription for both the beta blocker and an ACE inhibitor or ARB in the 90 days prior to device implantation. And the other alarming thing is actually, if you look at which patients actually received enough prescriptions to cover 80% of that 90-day period, only 28.3% of them actually received enough prescriptions to actually take their medications for that 90-day period. You might say, well, this study is from 2007 to 2011. Maybe we've gotten much better at giving our patients their appropriate meds, and unfortunately, you'd be wrong about that. So this is actually a study looking at the CHAMP-HF registry, which enrolled patients with HFrEF between 2015 through the end of 2017, and also looked at dosing of the medications. So if you look at this column over here, 39% of patients were not on an ACE inhibitor ARB, 34% of patients were not on a beta blocker at all. ARNI was quite low, but that might be due to the time period. But the other important thing is that if you look at the patients who actually achieved target doses of guideline-directed medical therapy in the trials, less than 20% of patients actually reached those target doses. And the other thing, this study also looked at patients who had systolic blood pressures of 110 or greater, or 110 or lower. And unfortunately, you would expect that if they had if they had higher blood pressure, you'd have better utilization, and unfortunately, that's not the case. So GDMT in the real world is still significantly underutilized. And I would actually argue that our clinical trial data is actually even more robust in terms of the benefits of ICDs, because unfortunately, in the real world, patients are receiving even worse guideline-directed medical therapy than they were in those clinical trials. As Emily pointed out, I just want to reemphasize that ICDs do what they're supposed to do in non-ischemic cardiomyopathy in every single trial except AMIOVERT, but I'm going to exclude that because there are only 3 sudden deaths in the entire trial. ICDs significantly reduce the risk of sudden death in every single trial, including DANISH. And whereas this event rate you may say is low, if you take the ESC guidelines, for instance, for hypertrophic cardiomyopathy, considering ICD placement in patients with a 5-year risk of 6%, sudden death risk of 6%, the annual risk in every single one of these trials is higher than that, in most cases much higher. And I acknowledge that hypertrophic cardiomyopathy patients are a much different patient population, have a much lower risk of non-arrhythmic death. And so perhaps that risk needs to be higher. But that kind of leads us into what I think is really the major issue in this debate, which has already been brought up, is that ICDs, the benefit of ICDs is really going to depend on the relative risk of arrhythmic death versus non-arrhythmic death. And I think we've known this for a long time. And the way we've really known it, even before DANISH, was just looking at elderly patients. And there are multiple trials showing that ICDs have less benefit in elderly patients. And one of my favorite ones is this one from Circulation in 2016. This was looking at NCDR in patients over the age of 65, where the mean age was 75.5 years. And 11.5% of them were enrolled in hospice during follow-up. And the median time from ICD implant to hospice enrollment was actually 1.3 years. And at 5 years, actually 50.9% of patients were either dead or in hospice. And so our elderly patients have a much higher risk of non-arrhythmic death and are less likely to benefit. And I think we've known that for a while. And so when DANISH came out, I actually didn't think those results were that surprising. They had a higher median age than the other trials, except for Companion. And the benefit of ICDs was still there in patients less than 68 years old. And so we've been kind of dealing with this problem of how you assess non-arrhythmic death and arrhythmic death for a long time. Ting pointed out some of the other tools that we have, including MRI. There have been many studies looking at multiple parameters. This is a meta-analysis of actually electrophysiological parameters that have been looked at to predict sudden death. The most strongest predictor is actually an EKG, or fragmented QRS, in microvolt T-wave alternans. And this data has been around for a long time, but none of this data has actually made it into clinical use. And the reason is, and it's for this data as well as for MRI and as well as actually for that Seattle proportional risk model, is that there's no prospective data validating actually their addition to LVEF as risk stratification in terms of what the accuracy and precision is for actually identifying those who are going to benefit and those who cannot benefit. And so I think that we can all agree that we do have to select our patients better and that we do need better risk stratification tools other than LVEF. The problem is that we currently don't have the data where we can confidently say, for most patients, who will not benefit from an ICD. I think on either end of the spectrum, it's probably easy. If you have a 50-year-old who has no significant other comorbidities and a large scar burden and MRI, it's easy to put an ICD in that person. It's easy not to put an ICD in the 82-year-old with CKD and COPD. But I think for everyone else in the middle, we need better tools to risk stratify them and to confidently say that you will not benefit from an ICD. And I think this limitation leads a lot of providers as well as patients to actually elect for ICD implantation. And so what's going to be really important in the future is that we do need a novel risk stratification algorithm. I completely agree that LVEF is inadequate, but we need prospective studies validating these additional variables in order to actually better risk stratify these patients. And I will hand it over to Dan for the last word.
All right, thank you, Alan. Let's try and share my screen. All right, can everyone see my screen?
Yes.
Okay, terrific, excellent. So thanks to everybody for a really stimulating debate on a very important topical area. Here are my disclosures real quick. So just as we think about the history of studying ICDs in non-ischemic patients, we need to think about when the trials were done. I know this has been mentioned a little bit, but 25 plus years ago, was when these pivotal trials were enrolling, with the exception of DANISH. And at the time, the investigators were using the best available tools to understand risk of arrhythmia and use of ICDs. And the best available tools, which were blunt at best, were ejection fraction and NYHA class. Really what these tools are trying to get at was the arrhythmic substrate. We did not have a great way of measuring the arrhythmic substrate a long time ago. And the good news is that we now have a much better way of understanding the arrhythmic substrate, therefore the risk of sudden death, and then by extension, potential benefit from an ICD. all of Alan's points about needing better risk stratification tools and better validation of these risk stratification tools, they're all, valid points. The reality is we're never going to repeat SCD-HEFT or DANISH, where we end up randomizing patients who, currently qualify to a defibrillator to not having a defibrillator. The logistics and the practical nature of those trials, it will preclude these trials from being completed. So I think we need to sort of, although from a purist perspective, that data would be incredible, realistically, we're not going to be getting a large pivotal randomized trial where we randomize currently acceptable patients to no defibrillator. I think it's very unlikely. And so what I think we should be focusing on is not implanting devices in everybody, or at least not recommending strongly that we implant devices in all patients with non-ischemic cardiomyopathy. And we need to use some of the tools that Ting had gone over. And this is one of the figures from the MRI paper that Ting had mentioned. And I think it provides a useful reminder for us. So, MRI defined scar identifies the arrhythmic risk. A very, very small amount of scar, which is commonly seen at the insertion sites and in mild forms of non-ischemic cardiomyopathy, that little bit of scar probably doesn't portend a very high risk of sudden death. Whereas once you hit that 5% mark or greater, the risk of sudden cardiac death increases, and the likelihood of ICD benefit also likely increases as well. So I think that this concept is very important. So it's greater than 0 doesn't necessarily mean high risk of sudden death, but certainly once you get to the 5% or more mark, we need to really be thinking more strongly about defibrillators in these patients. This is another piece of data from that same paper. And what is important here is what I have highlighted with the red boxes. And that if you look at risks of the endpoints in this study, the arrhythmic related endpoints, so death or ICD discharge or sudden death or ICD discharge, actually the presence of ischemic heart disease was not a significant predictor. What was a significant predictor was a scar burden of greater than 5%. And what that means to me, and what I think we should all be considering, is the fact that, the diagnosis of ischemic versus non-ischemic heart disease back in 1997, 1998 was really just a proxy for scar burden. And now we're able to actually measure scar burden. We can describe it, we can quantify it, and so we can do better than just putting patients in an ischemic versus non-ischemic bucket. Because we all know that there are patients with a history of coronary disease and even revascularization who upon cardiac MRI imaging have relatively small amounts of scar, if any, in a coronary distribution. Now, there are certainly some patients with dense coronary distribution scar, but we need to, I think, move towards a more granular approach to these patients. And so my main takeaways is that there are substantial limitations how non-ischemic cardiomyopathy is defined in these pivotal trials. There is no granularity regarding the subtype, as Ting had mentioned. And, I think we all know that a patient with sarcoid and an EF of 35% is at very high risk for sudden death, whereas a patient with an idiopathic dilated cardiomyopathy and EF of 35%, that's probably a very different risk profile. And these old trials considered both of those patient types to have non-ischemic cardiomyopathy. So it's no wonder that the confidence intervals were wide and the actual significance values were often borderline. These trials, as I mentioned, had no granularity about the presence or absence of an arrhythmic substrate. And so I would argue that in 2020, we need to be splitters, not lumpers. So talking about patients in terms of ischemic versus non-ischemic cardiomyopathy is I would argue most useful for understanding what's the right medical regimen to be on in terms of whether or not, secondary prevention of coronary disease medications are necessary. But in terms of looking at arrhythmic risk, we need to be thinking about the substrate. And, you know, the point is well taken that OMT and CRT both do significantly reduce the risk of sudden death and therefore ICD benefit. But we need to keep in mind that optimal medical therapy doesn't reverse existing scar, and neither does CRT. And one thing that, this is me just sort of looking a little bit into the future, that it's going to be an interesting thing to see, is what happens with the profile of patients who actually have out-of-hospital cardiac arrest with all of these improvements in GDMT, namely ARNIs and SGLT2 inhibitors. Because we're going to have patients who previously had high scar burdens, EF of less than 35%, got an ICD, but now, over the next 5 to 10 years, these patients are going to have better EF recovery. They're not going to meet criteria, but they still may have 5-8% scar burden. So that's going to be something we're going to need to stay tuned to and see how that plays out. Just wanted to talk very briefly and wrap up going over how we use some of this new information to guide conversations with patients and family members regarding ICD implant. I think for the most part, the discussions regarding primary prevention, ICD implantation, and ischemic heart disease has been relatively stable. For me, at least, this emerging evidence and discussion in the non-ischemic space has really informed a lot of how I do shared decision-making. And just for everybody's benefit, just going to briefly share the fact that it's actually a mandate for us as electrophysiologists to use a formal shared decision-making tool during counseling regarding primary prevention ICD implantation. You can actually access it through Epic under the Tools tab in Epic. Then you go to MD Forms and Tools and the ICD shared decision-making tool. It's a 2-page tool that goes over some overall pretty basic things about what is an ICD, what is the role of an ICD, and how can an ICD change my long-term survival and health status. And there's kind of an interesting set of figures down here at the bottom that, you know, pretty bluntly describe the fact that, you know, an ICD can protect you from dying suddenly, but then it sort of shows how your quality of life can dwindle down towards the end. And I think that's an important reality, but maybe a tough one to be discussing with patients when they're, you know, overall doing reasonably well and they're stabilized medical therapy, but it's an important conversation to be having. One important limitation of this tool is that it really doesn't have any information about subcutaneous ICDs, which we're using increasingly, and it doesn't really apply as well to CRT devices, right? Because CRT devices, as you all know, actually will improve the heart failure status. And this is really just about the ICD piece. This is the second page of the shared decision-making tool. This looks at data from the 5-year results of SCD-HEFT. So it doesn't incorporate the 10-year data. And it just basically goes over the number of lives saved and the number of patients who will die regardless of ICD implantation or not. And then it subsequently goes on to discuss deactivation of an ICD and complications with ICD implantation. Overall, patients seem to like it. I always ask the patients at the end of a conversation, did you find it useful? Do you like it? I haven't had a resounding, I love it, or a resounding, I hate it, but most patients do actually find it beneficial to go through. And at the very least, it's sort of a good guide for us to make sure we're going through the right things. So with that, I will conclude my comments. And if anybody has any questions, we can go through them. I see Erica was thinking about my last few slides. Excellent. All right, well, if there's no questions, I'll thank everybody for joining us for yet another remote cardiovascular medicine grand rounds. And as Oyuri had mentioned in the chat, next week, we're pleased to have Dr. Nanette Winger, Professor of Medicine and Cardiology at Emory University, giving remote grand rounds. So thank you, everybody, and stay safe.